So the importance of the mother in the maternal fetal medicine has not been so much updated or appreciated, while the fetal medicine has actually improved over the last few decades. So over the next few minutes, I'll be discussing a few case scenarios and the role of the maternal medicine in the MFM curriculum or the maternal fetal medicine fellowship. In the year 1960s, there was increasing number of obstetricians focused on the care of pregnant women with risk factors for pregnancy complications. This was one of the developed countries. They realized, and they first brought in 1974, the first maternal fetal medicine board certification, which was offered. In 1977, the Society of Perinatal Obstetricians has been changed into the Society of Maternal Fetal Medicine. After a decade, there was an interesting article in the Lancet which says it's a neglected tragedy. Where is M in the MCH, mother and child? The next several decades have seen so much of advances in the perinatology. The incidence of stillbirths have decreased substantially since the mid-1900s because of the advances in the perinatal care. Incredible advances happened in the area of the fetal medicine, neonatal medicine, particularly the fetal medicine where you can diagnose the congenital anomalies, the RH sensitization, and actually treat all these babies in the neonatal period. But did the same development happen in the maternal side? No, the morbidity has tremendously increased over the last years because of the reason of women with chronic medical conditions entering into pregnancy. Where do we stand today? There are generalist obstetricians, gynecologists. There are very few midwife-led units who help for the natural births. There is a gynecological oncologist who take the gynec-oncology into it. The medicine subspecialization has happened. The surgical subspecialization has happened. But this all excludes the MFM from many aspects of the maternal care. The maternal mortality in India, we know, has come down drastically. But have we achieved anything in the maternal morbidity? Not really. More and more women entering into the pregnancy with the chronic medical conditions, still the morbidity is very high. Let us see through a few case scenarios now. Mrs. P, 25-year-old with a BMI of 30. Her total weight gain was around 14 kgs. It was a spontaneous conception. The OGTT was normal at 24 weeks. She was normotensive throughout. Fetus was also a low-risk fetus. She was admitted at 37 weeks with reduced fetal movements, induced for the same, ended up in an emergency cesarean section for presumed fetal compromise and birthed a baby girl of 3.12 kg and discharged on POD2 in stable condition. But she came back to us on the post-operative day 7 with cough and headache. Her pulse was 78, but the blood pressure was high, 170 by 100. Remember, she is normotensive throughout the pregnancy, and she had bilateral basal Krebs and auscultation. She was shifted to the ICU and started on oxygen support. IV labetalol and magnesium sulfate was started, and she received diuretic. ABG showed a severe hypoxemia with respiratory alkalosis. Interestingly, chest X-ray is normal. So the 2D echo showed an ejection fraction of 69%, normal-sized cardiac chambers. These are her baseline bloods. The furosemide was continued once daily for 2 days, labetalol was continued for 8 hourly, and amlodipine was added to control the blood pressures. She was discharged after 72 hours in a stable condition. So she had a postpartum hypertension. Is it suspected pulmonary edema? Not really. Follow-up after 4 weeks, she's not on any antihypertensives. The home blood pressures were normal. Remember, all of us obstetricians should have a care pathway where we can look at the mother coming in with certain symptoms and then look at which pathway she belongs to. It's a hypertension pathway or it's a cardiopulmonary pathway. So if you have the early warning scoring system and if you monitor the pulse, the respiratory rate, the blood pressures, and then depending upon the symptomatology and signs, and we can get into this care pathway. So this is where the maternal medicine comes into picture. You should have care bundles. It's a case of postpartum hypertension, preeclampsia. As we all know, postpartum preeclampsia is very atypical, and it can be de novo following a normotensive pregnancy. 10 to 30% of the women can develop postpartum preeclampsia. Remember the triggers for evaluation of secondary etiologies when the mother comes for postpartum hypertension, especially if the requirement of antihypertensives is high and the clinical symptomatology of headache and also palpitations, and any hypertension persisting 3 months postpartum needs evaluation. So the Obstetrician follow-up doesn't end with 6 weeks. We should remember to follow them up of 6 months, 3 months to 6 months if some atypical presentation happens in the postpartum period. So the management considerations are the same: antihypertensives to blood pressure control, magnesium sulfate for seizure prophylaxis, and remember the diuretics, it should be always guided by the volume status and the long-term management for these women. So we have a postpartum preeclampsia patient information leaflet. Remember, what is it? What are the risks to you? What are the warning signs? What can you do? We should educate the women, and also when she develops any signs, she should be able to report to the hospital. Center for Diseases and Prevention Control, they have had a campaign last year. It's called Hear Me campaign. Any woman coming into your clinic with new onset symptoms, we need to have time to listen to her. And then rather than saying this is okay, we need to understand what really the symptomatology means for her. Remember the warning signs: very severe upper abdominal pain, severe headache, nausea feeling, and swelling in the hands and face, sudden excessive weight gain over the last 2 weeks, and shortness of breath. So the Preeclampsia Foundation gives us a nice guidelines, and we have to follow up these women, particularly the early onset preeclampsia, where you deliver all these mothers before 34 weeks. We should have a plan to follow them up at 6 to 12 weeks, 6 months, and 1 year, and there should be an annual medical review. So we have to help them and to understand and how best they can manage themselves in the postnatal period. So also remember to do a lipid profile in the postpartum period. There is an International Society for the Study of Hypertension in Pregnancy. It's called ISHIP. They have a beautiful guidelines 2022, which has been accepted by the FIGO, and it's worth following those guidelines and also following these mothers, because dyslipidemia is the most common cause of venous thromboembolism during pregnancy and also early onset preeclampsia. So we need to discover HEM to reduce the maternal morbidity and thereby the mortality. Coming to the next case, she's a 40-year-old fifth gravida. She had bad obstetric history and only a one live child, which was a preterm section, but still she wants to have a pregnancy, and she comes to you. She's advanced maternal age. Nowadays, 35 years is no more an advanced maternal age. We see more and more women at the age of 35 and 36. 40 years has become very common now, but we need to be watchful, and counseling is very important. And when you looked into her history in detail, she has a history of ulcerative colitis, and she had always had some episodes of bleeding per rectum. There are certain guidelines which we need to follow. The maternal medicine person has to spend time, understand in the preconception period itself what is the medication she is on, how much is the disease-free period for her, and what is the interdisciplinary consultation. You heard the previous cases, how the multidisciplinary team helped each other in managing these women, and also the medication management, we need to be very careful. We see most of the women now, after stopping methotrexate, after 1 month they conceive, and people would have terminated. 3 months is theoretical risk, 1 month is the absolute one. So if she conceives after 1 month accidentally, it is all or none phenomenon. Wait for an early pregnancy scan, wait for a nuchal scan. So that is one concept which we all have to understand. And most of these women with inflammatory bowel disease and ulcerative colitis, they will be on sulfasalazine. But remember to continue the folic acid throughout pregnancy. Please don't stop them at 16 weeks, because sulfasalazine interferes with the folic acid metabolism. And azathioprine can be continued. Monotherapy is always better for these women rather than a polytherapy. And also biologic therapy can be continued, but we have to measure the serum drug levels. So these are all reality. These mothers are coming to us. It's not a textbook thing. Obstetrician should have this awareness and refer to a proper maternal medicine person. Post-delivery care is also extremely important. What is the mode of delivery? Most of them have anal fistulas. They would have had the surgeries for that. So she's for a cesarean delivery. But the postpartum, how do you manage her lactation, biologics? So when does she start her biologics in the postpartum period? So all this is important for us to understand when a mother has a chronic medical disorder. And also we have to, about the vaccines, we should be given on schedule and avoid live vaccines in the first 6 months with in utero biologics exposure is an important advice, where we talk to the neonatologist and they follow it up. So here comes the role of preconception counseling to reduce the maternal morbidity. So mother has to be looked into, not only the fetus. Coming to the other mother, 26-year-old recently married. She's a known epileptic on anti-epileptic drug. She's on the polytherapy. So she wants to know whether she can plan pregnancy. So how do we counsel her? We cannot say you cannot become pregnant. We need to understand her and also do counseling, effective counseling. So uncontrolled seizures, better not to plan immediately. Taking high doses of anti-epileptic drugs, not immediately. Polytherapy, so ideal is monotherapy, but depending upon her epilepsy, she has to be on 2 drugs also sometimes. And sometimes there is a drug-resistant epilepsy, uncontrolled epilepsy. So we need to be carefully asking her about the compliance with the medication and also look at the other medical comorbidities. So you should optimize the maternal health preconceptionally, remain compliant with the anti-epileptic drugs, close follow-up along with the neurologist. So here the maternal fetal medicine person has to liaise with the other specialties. Avoid seizure triggers, manage seizures with the lowest possible anti-epileptic drug, avoid changing medication if the woman is seizure-free, and please don't stop medication on your own. We need to discuss with the neurologist, talk to the woman, and then only we need to change the medication. Avoid sodium valproate, consider changing to less teratogenic drugs, but if she is very compliant and doing very well, we need not have to stop the drug. So we need to remember the fetal malformations. Yes, there is an increased risk of congenital malformations, but these are the women who are mostly on levetiracetam and lamotrigine, newer anti-epileptics. They are considered safe in pregnancy. So while on monotherapy, the background risk is 3 to 5%, but while on carbamazepine, the risk is 2.2%. We have a nice websites where Terrace is one, Bump from UK is one. We can put the drug, know about the risk of malformation, and we can counsel the women. Not that all of us have to remember everything, but we need to have evidence when counseling these women. No more we use the FDA categories now. We need to have the drug, we need to have the available evidence to counsel these women. Now coming to the case 4, Primie gravida, 34 years. She came to our ER at 21 weeks of gestation with shortness of breath. She had a family history of hypertension and type 2 diabetes. So she has typical cough, waking up in the night with breathlessness, better after upright for 2 hours examination. General examination, the JBP is raised 3 centimeters above the clavicle, mid-diastolic murmur in the mitral area. The provisional diagnosis is a rheumatic heart disease, mitral stenosis, and New York Heart Association class 2. Rediscovering the M in the medical examination. With having all the multi-parameter monitors, we forgot to put a hand on the pulse, we forgot to auscultate. I think we should be back to our basics, inspection, percussion, palpation, auscultation, and percussion. Just not forget about our basics. And here, this lady with a cardiac problem, the 2D echo showed double valve affected, severe mitral stenosis, as well as the aortic stenosis and moderate pulmonary arterial hypertension. She's already around 24 weeks of gestation. So better ask the cardiologist, talk about, start the medications, the cardiac drugs. She was started on metoprolol, furosemide, and Penidur prophylaxis. And this is a 2D echo, which is showing the double valve getting affected, the mitral and the aortic valve. And this is a high-risk cardiac condition, isn't it? There is a low-risk, medium, and the high-risk, and this is a high-risk cardiac condition with a pulmonary arterial hypertension. So the combined counseling helps with the family. Sit together and counsel, evaluate the current cardiac status, and discuss the options of management and the maternal and the fetal risks. She underwent a post-balloon mitral valvotomy at 26 weeks, and the repeat 2D echo later showed a moderate MS with mild MR and a moderate AR and a moderate AS. Alleviation of symptoms and anemia corrected with oral iron. She continued her pregnancy. This was the fetal evaluation, the fetal growth, showing on the 10th percentile. And she went into spontaneous labor at 37 weeks, and she delivered in the ICU. It's always better to have one person monitoring this mother and allotting a ICU facility or an isolation room facility and delivering this lady. So 2.1 kg baby delivered a normal Apgar, and she required postpartum thromboprophylaxis because of the high risk. Always better to have the management plan and delivery for all the high-risk conditions. It's easy because we have lot of turnover of the residents with less clinical exposure, and it will be easy in the handover in the labor rooms how we monitor these mothers and deliver them. So we have this cardiac disease and pregnancy management plan and delivery. Every medical disorder have a plan and delivery so that it will be easy for the youngsters to follow. So I think it's time to place the M back into focus, the maternal mother into focus, rather than concentrating on the fetus and the neonate alone, because mother has to be looked after well. And I think we all remember the Barker hypothesis, Pedersen hypothesis, and the Frankel hypothesis. All this will affect the mother, and the maternal non-communicable diseases have been increasing nowadays. So the maternal health gets a priority. And in addition to this chronic medical conditions, we have the ACRITA, more number of cesarean sections, less exposure to the instrumental births, and these are the women actually getting more and more sections and getting into placenta ACRITA spectrum and being referred. And these are the women who have at high risk of mortality and morbidity. The risk of postpartum thromboprophylaxis, antenatal also, some women may require a thromboprophylaxis at 28 weeks. So the time has come now to place the M back into the focus. So to look at the statistics of the 2023, sorry, I couldn't update 2024, 40% of the pregnant mothers have medical disorders complicating pregnancy, and most of them are diabetes. First is hypertension, second is diabetes, then is the connective tissue disorder complicating pregnancies. And remember, we should have the near miss or the morbidity being looked at for each and every mother, and we should have the audits every month. And if you look at 2023, we have 9,777 women birthed, and potentially life-threatening conditions were in 13%, and 74 were life-threatening, and near miss was 73, and we had 1 maternal death. But in 2024, we had 5 maternal deaths being referred with a different chronic comorbid conditions where mothers have been referred. Either it is too critical stage or in a too late stage. It's always better you audit the morbidity. Mortality is coming down in India, but the morbidity still has not come down. Every institute should have a near-miss audit. And if we have a near-miss audit, and then we know how many mothers have potentially escaped near death. Multiple pregnancy, now this is increasing. So the near-miss audit last year from 2022 slowly showing increasing comorbid conditions in multiple pregnancy, especially the availability of the IVF pregnancies at every level. The near-miss multiple pregnancy contributed to 3.2%. We had 1 maternal death. This is a lady with a scleroderma, interstitial lung disease, and she had a 24 weeks fetal demise, and she had a medical ERPC followed by PPH and cardiopulmonary arrest. Unfortunately, we couldn't survive her. So putting M back in maternal fetal medicine, I think all obstetricians and gynecologists should think about the maternal condition apart from the fetal condition, doing fetal scans and fetal treatment and more fetal assessments. Then we have to put this M back. And in 2012, the first putting the M back in maternal fetal medicine session was held in the Society of Maternal Fetal Medicine annual meeting in USA. And they also had said there are 3 urgent needs that are identified. One is education. Mandatory rotation for all the maternal fetal people, because they come after post-M, they should again continue there into the labor room delivery and ICU. And also we should have active certification ACLS, and we should have simulation-based learnings, because now hands-on has come very less. And also leadership skills, there should be a training in the leadership skills. Clinical, we should have guidelines and care bundles. Thromboprophylaxis, we have a guideline. Cardiac, we have a care bundle. So postpartum hemorrhage, we have postpartum kits. Eclampsia is reduced because we have eclampsia kits. I think there should be a need, there is a need for the guidelines and the care bundles to prevent and manage maternal morbidity. There should be an increasing support to the maternal fetal medicine subspecialists, because they are specialized to understand, to read, and help the common woman with a lot of comorbid conditions and highly challenging medical problems. And critical, there is a very serious research gap. Case reports, case studies, or it is even you can do the prospective or the retrospective analysis of our own data in our country, and we should be publishing our own data. And all long-term outcomes after adverse pregnancy should be followed. We have registries. We have a cardio-obstetrics registry in India. I don't know how many of you are aware of. You can enter into that registry. So there are registries, and also the policymakers, the politicians, as well as the heads of the different institutions all should come together, and this all will help us to reduce the morbidity. And continued medical education is mandatory. We have a specialty of obstetric medicine because how much of exposure we have during our MD days to the medical disorders, and the complex medical disorders are increasing. There are dedicated fellowship programs. I think people should be encouraged to do these programs. And there is a Society of Obstetric Medicine India, CME. You can put your case into that and we can discuss the cases, because all of us should work together. So we should have updates, obstetric medicine dedicated, how we have fetal medicine updates. We should have an obstetric medicine updates, people who are specialized in the obstetric medicine. They can share their experiences, and there is a lot of advances in the pharmacology too. Newer drugs are available in our country. These are few obstetric physicians who can be, they have updated all our knowledge about it, and we can share our knowledge by publishing our guidelines and also our booklets so that it will be shared among the people. And finally, I can only say, the bigger the dream, the more important the team. And I thank you. If everyone is moving forward together, then the success takes care of itself. Thank you so much. Thank you, chairpersons, for this opportunity.